O'clock, so we're just going to get chatting to start with. I'm Smriti. We've met a few times, and I'm the director of programs at Pallium India. And welcome back, everyone, for today's session on communication. I think it's typical of these times to have challenges in communication. So, our lead facilitator for today, Dr. Param, is having a few challenges, but we're going to sail through it, demonstrating how communication can be done even in difficult times. Oh, there he is. I see him. Okay, there you go. Param is a dear friend and colleague and a friend of Pallium India's. And Param is actually a neurologist. He's a professor of neurology and epileptology at PGI Chandigarh, and passionate about communication in healthcare. And he coordinates the communications program for not just his own institute, but also for the Indian Academy of Neurology and the Epilepsy Society. So I'm very glad that he's joining us today. I will be co-facilitating with Param, and we have Vandana, who will be presenting us with a case, which we will then go on to discuss towards the last part of the session today. While we just wait for Param to connect, I'm going to ask that all those of you who have signed in with device names, if there are any, I'm just quickly going to check. Please ensure that your name is visible so that we can mark your attendance. And yes, and we have a few of our fellows. We've started a fellowship program in Pallium India, so a few of our fellows will be joining us as observers. Welcome. Okay, Param, how's it going? We can see you. You're on mute.
Dr. Param, you are on mute.
Starting.
There you
Okay.
go.
Can you hear me?
Perfect.
Hi, everybody. Sorry. So, yeah, I'm passionate about communication, but sometimes, it gets the better of us. Smriti knows there's some challenge going on with my Zoom and Pallium talks. I'm just going to share my slide. Thanks, Smriti, for the introduction, and welcome everyone. I just put two, ice-breaking questions. You can give it a thought and put it into the chat box. Then we can have a discussion. So just to start, I just want to have, I'm sure some of you are already exposed to communications and palliative care. So what do you think are the main benefits of having formally going through communication learning or training process? How does it benefit generally and especially the medical communication between healthcare workers and the patients and their attendants? And the second one is, what do you think, is the communication a natural thing or is it a learnable skill? So when you give your responses, I'll just start sharing my slides after that. Just give me a moment. Are tuned to it, and actually they've probably even read about it, so that is very nice, and that's, I think we can have a good discussion. So most of the points are very true what you said, and although sometimes there's a debate even between the experts in communication whether it's a learnable skill only or is there a natural. One of my mentors strongly believed that it's a totally learnable skill. My own views are a bit mixed, as someone already said, that it is both having a bit of a compassion and empathy in your personality helps, but definitely that is not enough. That is what I feel. And formal doing, because I know now, a few years back when I started going into communication, I thought, why do I need? I mean, I take so many talks in my neurology field and I communicate well, but there are a few things which we will go over briefly, that which sometimes are very technical, like learning a surgical procedure. So yeah, it has to be a mix of both, but largely trainable. So I'll go ahead with the. So today's learning objectives are, we've already talked need of medical communication. What are the barriers to communication? Very important. Then there are steps or skill sets required for good communication. And then how do we differentiate between good and poor communication skills, or maybe not up to the mark, I would want to say. And in major ingredients, as you can see on the screen, are developing proper listening habits, rapport building, paraphrasing what patients say and what they understand, and then reframing the whole scenario to get a comprehensive communication kind of a tool going with them. We've already gone through this, so I'll skip this. So this slide is why are we these days focusing a lot on communication? Because over time we've realized that, as you all said, there are so many benefits which we are missing if we are just putting medicine into the patient's mouth, whether we are nursing or doctor professionals. So this benefit has been coming over the last couple of decades, and more so now. One is, as the reason on the screen, that there is a lot of medical legal issues these days, and the research shows that many of the medical legal cases or complaints are based because of the poor communication between the clients or the patients and the healthcare providers. So that is important, and there are many more benefits. Before going to that, I just use this mnemonic every time: the 4 C's of good communication. So the first C is uh, candid. Candid, as you mean, is honest, and putting it very honestly. So although the crux of communication skill is twisting a bit of your style to make it more palatable, whether it's bad news or it is a serious illness or even a normal long treatment plan, but we do not try to twist the facts. So this mistake sometimes we make, that we just try to give a bigger prognosis, trying to cheer up the patient, but that is something we like to stay away from. The next C is clear, which is it should be said in the language which the patient understands. And because especially in our culture, we are a multilingual country, and it is very important to know what is the best language the patient understands. Actually, it's a requirement also these days in the medical legal, that when you take a consent or something, it has to be understood in their own language to the patient. So that is important again. The third C is concise. So as we go along, we'll know that the patients are in a very sometimes anxious mode. And if we give too much overload of knowledge to them in a go, they probably will get confused. So it has to be in a brief manner. And we should avoid medical terminology that also comes under the clear language. And the last one is complete. So as we'll see in the next short, more of a funny video, that if we do everything and we don't complete the communication, what can happen? So you see, this is basically exercise they do sometimes in motivational classes, where they build trust in the group. So a newcomer is made to stand on the chair, and he's told that everyone will gather around him, and then he's asked to fall and they will catch him. So he has to put their trust. So this experienced person is explaining everything to him and asks him to fall, and the other people will catch him. And so he does. So but you see that he just missed a small bit, that he missed telling him which side to fall. So these kind of mishaps can be avoided if we make sure that our communication is complete. Now, so you already mentioned quite a few things about what are the benefits, and there's actual medical research. These are based on papers presented that people who get communicated well and with empathy, they have better chance of controlling blood sugars and blood pressures, because maybe the anxiety level comes down, they know what's happening around them, and they have better pain scores, especially in chronic illnesses and malignancies and even otherwise. Um, they need fewer tests and referrals because they get satisfied with good communication. They don't go around hunting nursing homes and hospitals because they don't know what's happening. And once they understand the treatment plan, the compliance is much better, and it is seen that these patients have a better outcome who have gone through a healthcare provider, a doctor, a nurse, a technologist, whoever, medical administrator, who have had good communication skills. And in the end, as I said, it builds a better rapport with the doctor and lesser chances of confrontation. So anything else we need to talk about, Smriti, in this time, or anyone, any query? Or
Smriti ma'am, we can't hear you.
Sorry, communication problems. Actually, there's been a fair bit of banter on the chat box before we started itself. But I think there's one, someone also brought up conflict. Social workers encounter conflict, knowing how to diffuse conflict and not let it interfere with the issues that need to be dealt with is key. That's such a great point. And we will, I think, be covering that a little bit later. And Amla also talks about the fact that every person has a unique communication style, a way in which they interact and exchange information with others. And she's gone on to list the 4 communication styles, which passive aggressive, aggressive, assertive. So yeah, so that's going into it in a little more detail. What also we're talking about here is what we can use in our daily practice. So thank you, Amla, for that. And Avatar has asked a question: is communication rapport building? I would say that rapport building is just a fractional part of communication. It's one of the outcomes of communication, but it's not only that. So people have also brought out collusion issues and things, which we will come to in a little bit. So you can carry on, Param. I'll make a note of all these and flag them to you again.
Thanks, Smriti, and thank you everyone for those bringing out. So we'll be dealing some things as Smriti said today, and there is a next week there is a talk more about collusion and emotions, in which I'll probably deal with the anger situation, as somebody mentioned, conflict situation. So that will be taken care of in the next talk. So let's go on with what we're doing today. So now we know the benefits. What are the barriers to communication? So there are some seen and unseen barriers to communication. Let's start by what are the challenges faced by a patient. Again, as I sometimes repeat this power difference. I repeat during my talks, because in our culture, especially people who are attending from India, we know, and a lot of other places, the power difference between the patient and the doctor, or the patient and the healthcare provider, is quite a bit, especially in the government sector. And when sometimes we feel that we are doing a favor to people, and we become paternalistic, and we a little bit of a patronizing too. We've all done that sometimes, and the patient is like at the lower end of the thing. So this equality, which has come in many Western cultures, is still to catch up with us. So the patient may be timid, and they may really not want to ask too many questions to upset the doctor. The doctor may be very busy, and I can only tell one complaint, and other non-medical problems which may actually be weighing more on the patient's mind and causing distress. They don't think they can talk to us about them. And then sometimes, of course, patients can have physical disabilities like dysphasia or dysarthria, where they can't communicate properly anyway. Another important challenge faced by the patients is it's a continuation. It's the fear and anxiety. Now, this is something we sometimes miss, because we go to the hospital every day, and it's like going for a job, come back home, and life goes on. but you may have known in your friend circle or your family circles. I have quite a few people who are so scared of going to the hospital, and anytime if they have someone admitted, they will tell somebody else to go. They can't stand in the corridors. So this is something, if we inherently know that people can be very, very anxious, confused, sometimes frustrated because things are not going well. And on top of that, if they keep listening to heavy words like, cytokine storm and interstitial pneumonitis, especially in these days in COVID times, and myocardial infarction, they may get even more confused. On top of that, the sadness which maybe there can cause cognitive slowing. So I come back to this again, the video I present from a recent movie I saw, Dil Bechara. This is a Bollywood movie where it deals with a sick patient. And this is what this girl is telling when she was admitted in the hospital.
लेकिन इस हालत में इस वजह से मिलने से मैं डर रही थी। आई गेस हम सब डरे हुए थे। माँ बाबा को डॉक्टर्स के मेडिकल शब्दों से डर लग रहा था। जितना अच्छा डॉक्टर उतने ही कॉम्प्लिकेटेड वर्ड्स। बाबा सिर्फ सर हिला रहे हैं पर उन्हें कुछ समझ नहीं आ रहा।
So see how funny is it, like exactly what we discussed, and some script writer somewhere probably had undergone such an experience in a big hospital, and they verbatim reproduced what we talk about in our communication sessions. So it is important to catch the pulse of the patient and see if they are not anxious or overwhelmed, because sometimes if they are anxious, they cannot take a good decision on themselves. So this is another part of communication. We keep talking about discussing with patient and taking a joint decision, but we have to lift them up to a place where they are not anxious and can take a decision with us. Like again, an example, the last one here. This is from a recent transaction I was doing. I am not very good at these banking transactions online, and I was making a payment, important payment. Suddenly this dropped in, cancel transaction. This would cancel your transaction. Okay, or cancel. I mean, I didn't know what to do, whether both would cancel the transaction. And then suddenly my son was there, and kids are very smart these days. So he said, no, if you say okay only, then transaction will get cancelled. So I was not an expert there. I was not a doctor there. I was kind of a patient who got confused and was paralyzed. So he just pressed cancel because I was scared to do so, and then it went through. So in sometimes the point here is that if they are not able, we don't push the patient to take immediate calls. We hold their hand, and sometimes we have to take them over the line. Like in what I do many times is that if they can't decide, we tell them that they said, what will you do? So, I mean, I can tell them what to do. So I say, maybe if I was in your place, I may have chosen option C. And then if they're okay with that, we take their consent and move on. So what are the challenges faced by healthcare workers or healthcare professionals? The biggest question every time I hear, especially from resident doctors, is that where is the time in a busy hospital? It's a luxury. And well, partly true. Initially, we need to spend a little more time than we do. Only then we can have good communication. Everything comes at a price. But again, as you see, research has shown that once we start doing it as a second nature, routinely, actually it could be a time saver. If you can see here that the consultations times actually were lesser when proper emotional cues were addressed. And it is logical. I mean, it's not something we can doubt much, because if you, as we said, good communication, good understanding, plan made, patient follows treatment, doesn't default on treatment, and next time they come, and the time taken is less. Otherwise, many times the patient goes out of the consultation room, stands in the door. These are called the door questions. They will stand, come back, and scaredly ask you, oh, I didn't ask this. Oh, I didn't ask this. So if we had addressed those questions upfront, patient doesn't need to spend another 5 minutes to ask them again. Then there are other problems which are sometimes personal and sometimes general. Sometimes people may have emotional insecurity We can't handle if the patient starts crying or get angry, and these are the things are addressed in the how to deal with them in the either it's a palliative care or communication settings. And a lot of times we are very defensive in our interrogation. We want to play safe. We want to ask the safe questions. So, like this example where this patient is asking, Doctor, I'm so worried. I can't sleep properly. I have pain in the back. So let's say I'm an orthopedician. I don't want to talk about that because I think I may not. So I suddenly shift to the pain. Tell me about the pain. Although pain may be a minor complaint, but I just want to be safe because that's within my domain. And sometimes we don't inquire beyond the physical, that how are you feeling, how are you coping with your illness. So these are all points which help us give a holistic kind of help to the patient rather than, as I said, operate them or put medicine into their mouth. Then it's very common is that same continuation of the same thing is we find ourselves doing it many times, and you want to get a positive answer. You say, oh, your pain is better today, isn't it? Aaj achhe ho. So the patient gets very this thing that if I say no, then he's not going to be happy. So the patient may not give us a honest answer. And so the ideal is that we use open-ended questions. How are you doing today? And leave it at that and give them time to respond. That way they will not feel scared and possibly give us their thoughts. Anything we need to talk?
So Param, there's, well, people have raised a few things about not using jargon. I think that's absolutely right. I think it was Albert Einstein or someone who said that if you can't explain it to a 4-year-old, you've not understood it yourself. So we need to actually meet people where they are and de-jargonize our language. So, instead of metastasize, say spread, so I think we spend a lot of time learning Greek and Latin, and then we want to use that Greek and Latin on people that don't understand Greek and Latin. So very important point about no jargon. Avatar has also mentioned that questions must be prioritized by patient before the visit. That I feel will only happen if we urge them to do it. So typically when I set up a consult with a doctor, between a doctor and a family, I usually tell the caregiver that it helps to clarify your own questions if you write it down beforehand, simply so that in that moment you don't forget something important that you want to ask. But I feel it's also important to urge them that no question is stupid. People feel that they're asking a silly question, but I think it's important to explain to them that it is their body. Somebody brought up a rights issue. And when you talk about power dynamics within the healthcare system, that is a very real power dynamic. But that rights issue is a bit of a convoluted one. And it's up to us to encourage people to, it doesn't come naturally in the Indian context for us to see it as a right. Or to, this idea of autonomy over your own body, which Dr. Raj talked about in our medical ethics session. So really to expect the patient and family to do it may be a little too ambitious right now, but we can encourage them to start thinking along those lines. How they will be received by the healthcare system, I mean, that's a different story. So, but but great, very enriching conversation, Param.
Yeah. No. And this, I totally identify with that because our government is moving towards that. The healthcare regulatory bodies are moving towards it. I don't think we have a choice as healthcare providers to let it happen or not. There is a health charter on the website of the ministry, and it talks about so many things which the Western countries are doing, like as communication, telling the diagnosis, telling them options, both cheap and very expensive ones, and not withholding information. So I think this awareness of proper communication is coming at a very right time, because if we don't catch on to it right now, we might be at the receiving end of things. So I totally agree with these points.
Yeah, and I think shared decision making is also getting more formalized, where and that is, I think, a pretty big cornerstone of palliative care approaches, where the decision is made in conjunction with the family. And we keep saying this, medicine is not something that is done to somebody, it's done with them for their benefit. Dr. Rajni has raised a few points specific about ICU settings, which we will come back to later. Param, you can carry on.
All right. Yeah, no, it's okay. Fine. I'll carry on. We can keep. I might overshoot a little bit because we incorporating the discussion. I like it this way in between when the points are relevant. So yeah, carrying on. So this slide is only about from our COVID talks because this is the COVID time and still very active. So there are increased challenges in communication and. The two main things are, one is the distance. Sometimes we don't even end up meeting the patient's relatives, families ever. And the patients don't get to see their families for a long time. And unfortunately, they pass away. They never see them once they leave home. So these are huge issues and people are trying to sort them out, trying to make as near the normal, which it used to be if the attendants can meet the patient with the PP or something, but these are things still work in progress. The second one is our attire inside the COVID wards, which is like a spacesuit, as you can see. And from a smiling or a cheerful healthcare worker, you become like a robot, and there is no way to tell one from the other. So these are all added anxieties and challenges during COVID times. And I mean, there are possible solutions. People have tried, like putting their pictures and big names on their PP suits, so that when we keep going again, there's a rapport building with the patient. But anyway, uh, it's very important. And I personally, sometimes we forget in a busy rounds that we don't introduce ourselves. We just go and so that we are known, and we ask the patient, sometimes not even calling their name, and kya haal hai aapka? Sometimes the first time we go in, we ask, acha inka test ho gaya? That may be very unnerving for the patient. So it's a good, I am so and so, I am Dr. Param, I am your nurse so and so, I am your resident doctor. There's no harm just introducing ourselves, so that somebody else comes and asks, they know who came and saw them. It doesn't happen many times. So this is something we all, I think, can incorporate in our practice. So sometimes the environment is a barrier. In busy government hospitals like ours, we know that especially in the residents' rooms, the lack of privacy is a big issue. There is, you're talking sensitive, history from a patient, male or female, and there are 10 people standing around and they can't tell you properly. So as far as possible, where the system allows, we should always try to maintain patient's privacy to get a proper communication going. Noises, distraction, especially these days, mobile phones is a big problem, that every time you start talking to the patient tells you something, our call comes, we take the call, what were you saying? So that can be, quite distressing for the patient. So we need to take care of our not taking calls in between too much, unless of course you're in emergency. Physical barriers, sometimes big consultation rooms, you see this big desks, well, not as big as this one in the White House, but big desks. So this also needs to be given thought to, that how are we sitting with the patient? And something like this, when you're sitting at right angles or nearby, where you can talk to a person without that proper barrier. As I said, again, that power different, and beyond this huge table, if you see, like you're sitting in an interview or in front of a judge, you get intimidated. So we are the ones who need to make sure that the patient is not intimidated by our things. And these days, of course, additional problem is the virtual consultations, which are making it difficult to really, the non-verbal part of it is not being done. It's a big problem to carry out the non-verbal communication. Okay, so these are the main things. So I'll go on from the next 3 slides are about the skill sets, about any situation where we are interviewing the patient or discussing their plans. So straight away going to that. So skill set 1 deals usually with setting up the meeting. So as someone mentioned, I think in the comments, Creating a rapport is very important. Only then the patient will open up to you. So introducing, greeting the patient, then attend to the privacy. We already talked about that. And of course, our time is important. So we tell them that we have the next 20 minutes or so that the patient also knows they have to talk important stuff. Then eliciting all the concerns. So that is important. Patient, as Smriti was saying something, that we make lists and everyone doesn't come with the list and prioritize. Most will not come with the list. And many times they will start with the non-important stuff and this important thing will come in the end. So it's just good idea if you tell them, just make a list and tell me what all you have. And then you come to a mutual goal. That what is your main concern today, and from your medical knowledge, you combine the two, and this is what needs to be addressed. So this is how we set up a good meeting plan and then negotiate the further plan. The next part of the skill set is history building. So in all medical branches, especially in mine, neurology, we say that history is 80 to 90% of the diagnosis. And I'm sure in other different percentages, but history remains very, very important, history taking. So open the conversation, how we do it is very important. We talked about open-ended questions. We talk about attentive and reflective listening. So that is very important. Sorry, I missed that. Yeah. So attentive reflective listening is that one is not distracted, really into looking at them, making eye contact and showing your attention and actually being attentive. And reflective is that you kind of catch what they're saying. And as we said, rephrasing it so that the patient also confirms that we are getting what they're saying. Then respond with empathy remains everywhere, whether it's serious. We will be discussing it in the serious illness communication, but it is important everywhere, and this will keep coming up throughout the palliative care talks. And then the next is to actually build on the history and make a clinical plan. So in this, what we use is we share information. So from there, we gather, we make a plan, we discuss it, and we call it this art loop or ask, respond, tell. So we asked already the history, we respond this thing, and then ask the patient to tell us what they've understood, what we also call as teach back. It's a very, very important. I mean, I face it every day in my epilepsy practice. You tell the patient that you take this anti-epileptic drug for 3 months, come back after 3 months. So you know what you mean. You mean that after 3 months you come back, otherwise you continue taking it. But what happens many times that they take it for 3 months, for some reason they can't come back, they stop it. You said 3 months. So ask them then to teach back is very important, and then go back and explain the points which are not clear. So this basically sums up a good communication interaction with the patient. So yeah, Smriti, you were talking about shared decision making. So that's something we need to understand the concept. Some of you are, I can see, already very primed to these things. But so let me just take us through in the next minute or so. What we were used to doing was what we call paternalistic, this thing that I tell you what to do, or we call it my way or highway thing, that you either listen to me or you just go away, seek another doctor. Thankfully, we have changed from that. We have moving towards an informed medical decision making. We tell the patient, we tell them the treatment possible, and then we start one of them. But usually it's what is more acceptable to us in the end. So it is a step forward, but not complete. So what is shared decision making is, it's a two-way loop, as you can see here in this slide. So there is an information recommendation, as is in the informed decision making. There's an important other side loop, which is values and preferences. So this can be very, very important and easily missed if we don't actively sit down them and ask people what they want to do with their treatment, with their life, especially in choosing long, serious, expensive treatments, especially when you're in a serious illness and maybe could be fatal illness. what you want to do. And sometimes it can be a big problem when the patient doesn't want to take the treatment we feel is the best or even life-saving for them. So this is a point totally to be learned by us, that it's patient's right over their body, as Smriti and I think somebody in the chat also said. So if they want to refuse, we get upset and say, are you mad? Don't you know it's going to kill you? Take it. So this is where, this is a step beyond routine treatment, providing them support, and it can be done. We've tried it, that, okay, this is totally not what I would want you to do, but if you choose to do this, you can still come back to me. I will be your doctor. I will guide you through this. Although we differ in this, I don't stop taking care of you. So this is something we need to go. So this is where we are wanting to go in shared decision making. There are a few do's and don'ts. I think I'll finish off and then we can have any further discussion. So yeah, we already talked about make eye contact, and even if you're in a mask in COVID times or otherwise, sometimes we wear these masks. We all know a lot of smile comes through our eyes and from our voice. So even if we are fully clad, even if we are in a PPE or even otherwise in a surgical gown in normal times, it's very important to remain cheerful inside. It does show to the patient, even if you are not totally visible. Another small thing which we, again, we all do it out of good faith, is that try to cheer up the patient. Don't get so worried. It's a small problem. You'll be fine. Like in COVID times today, only 3% have problem, 97% are fine. But there's just so much fear inside the patient's mind these days from so much of media and internet they can look up, that it is not a good idea to trivialize their fears. And on the other hand, we want to support them by saying that I know this may be causing you anxiety, and I can understand why you're feeling this way. And if we go that way, which is called normalizing their emotions, they'll be able to trust us more, because then they'll feel that someone really cares for you, and they get you. Oh, I think wow, finished on time then. So this is what I wanted to say. I mean, communication is a very huge. We do it like 8 modules over a day or sometimes more, and so into 2 sessions. But I've tried to gather the gist, and we have time. We also have a case presentation by Dr. Vandana, and we. We can discuss that time. So I like to thank, because in addition to my own slide, there's a lot of slides I'm using from the Pallium India and Palli-COVID module, which we use for those talks, especially Dr. Biju and the rest of the team. And my mentor, Dr. Geeta Mehta from UCSD also. So Smriti, I think I'll stop here. I think there's a lot of interest in discussion. Maybe we want to take that up.
Yeah, so I think we'll spend about 5 minutes just sort of reviewing some of the things that were in the chat box, Param. We can stop sharing the screen. Yeah. And then we'll move into Vandana's presentation, following which we can continue the discussion. Interestingly, a lot of people, sorry, there's some echo. 1 minute, yeah. So interestingly, a lot of people here seem to be quite well versed with various models of communication. So I've received quite an education also looking at the chat box, the SBAR, the SOLAR. We also use the SPIKES protocol in palliative care settings. So actually, yes, there are several different models that might be appropriate in different settings. Of course, following a model is really not like following just a formula. It's important for us not to fall into the trap of formalizing these things, because it's important to remember that a lot of this has to do with the personality you bring to the table. So that would be something for all of us to bear in mind.
Smriti, sorry to interrupt you.
No, go on, please.
You know why? No, because I feel so much about what you said, So when a specialty starts, and I have attended the international meetings on communication in healthcare, and when there is a 4-day thing only about this thing, sometimes we're dealing in 2 hours. Many things, models will come up, and mind you, all of them are quite good. But as you so rightly pointed out, my personal view when we sit over the table and discuss these things is that not to get too carried away by those things. And the basic thing, like we used to say, a lot of old time doctors, that this was just a part of their practice, normal practice, this good communication. And from there we come to like highly technical models. So it's very, very personal, and what you want to use, what you don't want to use. And I don't think we are bound by those models. We all use different styles as long as they help us. And I feel that if we are not sounding very model based and not very, that might hinge on sometimes a little bit of artificialness. If we incorporate the models and bring it in our own way of doing it, that'll be great. Sorry for interrupting, but
No.
it's a very valid point you said. Yeah.
Thank you for that. And there's a comment here after which I'm going to hand over to Vandana, because I think we can get a bit carried away, and then we won't have much time to discuss the case that she's presenting. So Amla has talked about how knowing how to ask the right questions to get the necessary information. Now that's a skill, and that requires a certain level of, I guess, practice, also learning to pick up on the cues, and also giving people the space to ask the questions. And I think what we need to remember also is that silence is a very, very powerful tool. Not everybody is comfortable with silence. And sometimes we find that silence awkward, so we jump to fill it in. Sometimes a patient or a caregiver needs that silence for them to even assimilate their thoughts, and for us to be present with the person can be a very, very powerful thing. So that's something I just want to put on the table. And also, Amla, what you've said brings to mind the fact that communication is one of those things that once you develop competence, you can also bring a lot of creativity to it. And that's a great thing that communication offers us. So with that, I'm going to just stop for the moment and hand over to Vandana for her case presentation. Hi, Vandana. Welcome.
Hi, Smriti. Thank you so much. Good afternoon, all. My name is Vandana, and I am a palliative. I am a counselor, and I deal with palliative patients. I'm with an NGO called Cope with Cancer, and I work out of Tata Memorial Cancer Hospital. So today I'll be presenting a case of a patient who was diagnosed with. One moment, please. Who was diagnosed with stage 4 cancer, and I will then I'll take it up from there. So this is about Mr. M, who's aged 48, male patient, who was diagnosed with non-small cell lung cancer, stage 4. He's working based in Mumbai and working in the secretariat. So when he came in and he met the oncologist, he had complaints of intense coughing. He had difficulty in breathing. He was panting, poor appetite, extreme fatigue. Before this, he was being treated by the local doctor there, and who kept saying the pollution's got to you. You're wheezing, you've got allergic asthma, you've got bronchitis, but nothing helped. So when nothing helped, he was referred to Tata Memorial, and that's when he came to the thoracic department there. The biopsy was done, and it was, a stage 4 lung carcinoma. The diagnosis, yes, both the patient and the caregiver were aware of the diagnosis. The prognosis for the patient was after the diagnosis was told to the patient, there's a protocol at Tata, the patient was sent to me for counseling. And before I spoke to the patient, I had a word with the wife. The wife told me that the patient is temperamentally very weak. So she requested me that at the moment, when the diagnosis was made, not to divulge the magnitude of the disease. So I spoke to the oncologist, and this is what was decided, that he will not be told, because the stage for a patient who's been diagnosed with cancer, I have a lot of patients who say, what is stage 4? Stage 4 means I will not be cured or I'm going to die. So this was decided that the patient will not be told that it is a stage 4 disease. Though the wife and the daughter knew that Mr. M's days were numbered, the patient was explained that it's palliative care. He knew that the intent is not curative, but it's palliative. And the family also knew it was palliative. So this is the family overview. Mr. and Mrs. M had a love marriage, and they have a daughter, Mrs. S, who is Miss S, who is 23 years old. So when the diagnosis was made, when he came in, Miss S was still studying. Mr. M's parents, Mr. P and Mrs. P, are still alive, and so are Mrs. M's, but they don't get along with Mr. M at all because they had a love marriage. So basically, there is no family support for Mr. M. Mr. M is the only earning member of the family. Like I said, there is no family support. And Mr. M's daughter is unmarried and still studying. This is the Ecomap. So Mr. and Mrs. M, being very spiritual, believed a lot in God. So when they came to me and we started talking, the first thing I did was when I met Mr. M, he was shaking and he was crying. His first question was, why me? And at that moment, he just needed a little bit of emotional support, plus the stigma attached to the disease. So what I did was I just held his hand and we spoke about the disease, how cancer is not transferable, it's not contagious, and that kind of put him at ease. So, and then he started talking about his faith in God. So both the couple, they took a lot of strength from the God. So the temple, there's a mutual exchange of energy from the temple. Because of the stigma, like I said, associated with cancer, the support from family and friends. Family, any which ways, wasn't supporting them. And friends were hostile because in the strata that they live in, cancer is supposed to be like contagious or maybe not a nice disease. So he was kept out of the main ecology of the society. Then the volunteers at Tata were a great help to him. The daughter has a boyfriend who was again very supportive of the daughter and the parents as well. The doctors at Tata Memorial were extremely supportive of Mr. M. Social worker did everything possible to make Mr. M comfortable. And the colleagues were, because of the stigma, they didn't want physical interaction with him. So it was a very weak interaction, which Mr. M found very draining. This is the socio-economic overview. Mr. M is the sole breadwinner of the house. Because when the treatment started, they started in the private wing of TMH, considering that it was cancer and they didn't want to wait for too long. As the treatment started, there was a lot of money being spent. And because of that, he lost his job. They live in a rented house, no family support. There was the pressure of the daughter still studying. The daughter is unmarried. Lack of social support, like we spoke about in the Ecomap. Treatment being extremely expensive was draining the savings and depleting finances. So before I move on, I just want to speak about certain things. When the diagnosis was made, Mr. M was put on first line of treatment. And at that point, a lot of patients do respond positively to the first line of treatment. So he was very positive about responding to the treatment. And although he knew that he was in palliative care, but a lot of palliative patients can live about 5, 6, 7, 8 years. So he knew about that. Unfortunately, he did not respond to the first line of treatment. There was a lot of counseling happening, a lot of talking to me, a lot of talking, but he was all this while, he was very inhibitious and had a lot of, qualms about talking to the oncologist. Why? I think he feared what is going to happen next? So when he stopped responding to the treatment, the first line of treatment, he was put on the second line of treatment. Unfortunately, that also did not work. Then when that did not work, so Mr. M had the fear of death. He did not have the probably the courage to speak to the oncologist, and the oncologist also somehow was playing it safe. He did not mention to Mr. M about the impending death. Then Mr. M had anxiety regarding his wife's future, about his daughter's wedding. Lack of family support gave him a lot of anxiety and stress. He was feeling guilty. This was the feeling of guilt was weighing him down majorly. Each counseling session that we had, he would talk about being a burden on his wife, how he feels guilty that he, instead of being, the man taking care of the two women in his life, it is role reversal. So he was really brought down by the feeling of guilt. This is the total pain. Physical all these attribute to the total pain. Physically, he had immense difficulty in breathing because this disease had reached a stage when nothing was working. Even immunotherapy did not work. He had pain in the body. There was extreme indigestion. There was discomfort due to water in the lungs. And also to drain the waters, in non-medical terms, a bag was attached outside to remove the fluid. There was pain due to edema. Psychologically, like I mentioned, he had this huge fear of death. He did not want to face the question of death. But here I want to add another thing. But when the doctors put him on best supportive care, that was the time he and I had a very open talk about what was going to happen. So at that point, he accepted that he was going to die, but like all human beings, nobody wants to die. So that was also there. Then there was uncertainty about how many more months is he going to live? How many more months is the suffering going to continue? Anxiety about not responding to the treatment, wife's future, we've already spoken about it, daughter's marriage, lack of family support, and again, the guilt. Socioeconomic. One thing that kept bothering Mr. M is that there was no other earning member in the house. The finances of the house for running the house were totally on him. So he kept feeling that if he were to die, what will happen? There'll be no steady inflow of income. There was loss of job because of treatment, rented house, how the funding of daughter's education will happen, marriage of daughter, lack of social support, treatment being extremely expensive and depleting finances. So the marriage of daughter was hugely playing on his mind. I think that also attributed to the total pain. I would say 25% of the total pain, if it's in terms of 125% was that as a father, if I die, I will not be able to give my daughter away in marriage. So at that point, I and his daughter had a very open conversation about the daughter was seeing someone that time, and it was decided. The wife wanted to keep it a secret, so it was decided that before he deteriorated any further and he stopped registering things around him, they would get the daughter engaged. This was one of the points. Spiritual, though they were very, very spiritual, but always it came down to one question: why me? I am a non-smoker, I'm a non-drinker, I have not harmed anyone. So why is my karmas? Is it my karmas? Why is God punishing me? So that also added to his total pain. So Mr. M passed away 6 months back. He was put on best supportive care. He was in touch with the palliative department at Tata Memorial.
Hello.
And I was in constant touch with them on the telephone. And the daughter was, actually engaged while he could still register things around him. And 6 months back, he passed away. So I'm still in touch with his wife. The wife also needed counseling. So this is about Mr. M's case. These are the questions that come up. Do you think it was all right for the family to collude with the counselor and the oncologist and hide when he came in? Was it okay for them to hide the facts from Mr. M? Why was the correct communication important in this case? Like it's being discussed by doctor also, that how important is correct communication to the patient. So why was the correct communication important in this case? What, in your opinion, were the barriers to communication with Mr. M? Mr. M, like I just told you, that was put in best supportive care. Who could make him and the family understand what best supportive care means? How important do you feel is it to communicate with the wife and the daughter? So that's my presentation. Thank you very much.
Thank you, Vandana. And I'm going to now invite people to share their thoughts on some of the questions that Vandana has posed for discussion. And I encourage people to give their opinions. I've made a note of the questions, so I will let's try and take them. But before that, I'm going to also invite Param Param's going to be on this interactive session as well. So please do share your comments and thoughts. If you'd like to share something verbally, then please do raise your hand, use the raise hand option, and we will unmute you from the Pallium India side. So yeah.
Yeah, Smriti and Vandana, thank you for that case. Yeah, it's. I mean, we all know how important these conversations are, and possibly one of the toughest. And personally, from the communication point of view, I feel that this is something we really haven't found maybe the 100% correct model for. So this is that's why you're presenting the case and there's a doubt. So no doubt, there's two. I mean, I would look at it in two ways. One is honest communication, the technical way that tell everything every time. There are some good ways of doing that, which we'll talk about in the next talk also. But yeah, that what important, especially in the cancer patient, like what you're presenting, is that what we try to do is that before we have the report, before we have the knowledge that it's a stage 4 cancer, if there is a chance to get the patient's consent on that time, we are honest, we don't know it is going to be a serious disease or not. The patient doesn't know, the family doesn't know. So if that is the time we can get the patient's consent, that if when the report comes, whether it is good or bad, who is it to know, whether you want to know it or you want to delegate somebody, that sorts out a lot of problem. Having said that, that doesn't happen many times, in practical situations. Sometimes the patient is not there at the time of report, only the son, daughter or wife comes. So I can see the quandary which this patient was put in, although they are again trying to do the best for him. But the main crux here was that he could have planned much better if he had known. So this is a tight balance according to some people, depending where you stand on your values and your beliefs. One is that whether to tell the patient they're going to be dying in the next 3 months or so. Other is letting them decide their life. And I'm sure at the receiving end also, there are different type of people that who would want to know and who would face it very bravely and kind of plan their life in the next 3 months. And there'll be some people who kind of suddenly become depressed in grief, as Smriti is the best person to talk about that Kubler-Ross curve to go. The according to me, the last line here is trying to differentiate best way possible between those two type of people. So coming back to what I said is, if we know the personality beforehand, if we know the person beforehand, if we are lucky to know them, and we ask them that who would it be, we tell, that can solve. But I understand there is, it doesn't happen many times, leads to these kind of confusing situations.
Thank you, Param. And I'm just going to, I'm going to take Vandana's discussion points one by one. I'll read them out. The first question that Vandana had posed is, do you think that it was all right for the family to collude with the counselor and the oncologist? I'm going to hold that question in abeyance, Vandana, because in our next session on communication, we're specifically going to deal with collusion. And the thing is that collusion itself is such a convoluted subject with a lot of value issues in it. I will, however, mention that I don't think it's a question of if it's, I think collusion is nuanced. There's an intention behind it. Very often the family thinks of it as them protecting the patient. Therein comes the question of autonomy again, because where we think we know the patient better, they will be frail. Like what you said, he's in a fragile state of mind or whatever, it might break his spirit. Very often that is the caregiver's words. And what I'm going to leave the group with is the question, how often is it their own fear that they are projecting onto the patient? Because once you open up that conversation, you're actually acknowledging death. And I wonder there who is most uncomfortable with the topic of death, whether it's the person who's dying or the person who's going to lose a loved one. So it's all a bit of a mix. People use the word hope a lot. Again, we will talk about realistic hope versus unrealistic hope in next week's session. So I'm not dismissing this question. I'm just placing it on a shelf so that we can discuss it in a lot more detail and give it the time and attention it deserves next week. Coming to your next discussion point, which is why was the correct communication important in this case? And Vandana, I'm going to ask you to start things off on that discussion because you know this case so intimately, and then I'll invite others to please give their opinions.
Yeah, so like Dr. Param said that when a patient is diagnosed with stage 4 cancer and is put on palliative treatment, somewhere they know that a stage 4 cancer is giving them a certain, a limited time to live. So the correct communication becomes extremely important so that the patient can plan. In my mind, the patient can plan for the family, the plan for, like in Mr. M's case, could have planned better for his daughter's education, could have also planned in such a way that the wife wouldn't be left without a job. So having a proper communication about the reality of the disease becomes extremely important. And also I feel ultimately it's the patient who's going to, fight or live with the disease. So it is also extremely important for the patient also know how he is placed in terms of the disease. So that's my viewpoint, why a good communication is important in this case.
Absolutely, Vandana. Is there anybody else who would also like to weigh in on this discussion? Planning could not go easy as there's a lot of burden of uncertain death. Yes, so we also will be doing a session later. We're actually, one thematic group of topics that we're covering is living and dying well. And we're going to be talking about end-of-life care. We're going to be talking about advanced care planning in very, very great detail. So that is a conversation that we will be having about when is this conversation started? When do we have these conversations within our families? Planning is a little bit, it's a little bit tricky because in India, there's this saying that, not a saying, there's a belief that it's always too early to talk about death until it's too late.
Exactly.
So, I mean, yeah. So nobody likes to talk about it, about falling seriously sick. Rajni asked me. Sorry, please go on, Vandana.
Can I? Why planning is important, or would have been a better planning would have been important, was Mr. M was working in the secretariat, and for some reason, some administrative or some governmental reason, his pension, it was a pension, he had a pensionable job, was stuck. So when he passed away, there is no one to take it up forward. And also it was, he was given a short time to live. So a little bit of planning, like in terms of seeing his daughter being engaged, reduced his total pain. So I think planning is extremely important. A good planning is very, very important, I would say.
Absolutely. There's no disputing that. I think we also talk about the fact that, now that they're here with us and the planning was not done, what can we do about it? Param, here's a question that I'm going to pass on to you from Rajni.
I read that.
Yeah, please.
Yeah, I can respond. I was waiting to respond to that. Thanks. Yeah. So is it that if the patient doesn't want to know? So is that the one you're talking about, Smriti? Same one?
Yes.
Yeah. So what patient autonomy means is both. If they want to know or don't want to know. If they want to know, we should be telling them, however grave the diagnosis is. And if they've expressed their desire, clearly expressed it to know, even if the family doesn't want it, it is our moral and legal obligation to tell. If the patient has expressed it that I want to know everything. Same way, if the patient expresses that I don't want to know, I mean, we can't be chasing them around to tell the diagnosis, but yes, someone needs to know. So we need to record it that the patient has expressed desire not to know if it's a bad prognosis, and nominated family members. It has to be on the record because somebody needs to know our responsibility, and it could be the family. And if at all, rare cases, there is no one to know, I think it is a duty to tell the administrative areas, and it can be taken up with, sometimes it's a magistrate, depending upon local laws or whatever. So someone needs to know. It doesn't have to be the patient if they've expressed their desire to. I hope that answers that question, Smriti. Yeah.
It does, Param. And I'd also like to add to that, because the question also has been raised about this age has been raised as a concern, and also what is the right time. So I'm going to take the right time question first. Rapport is really important. I don't think we can go into, this is a very, very difficult time in somebody's life. Now, we've been taught to share the truth, to be honest, to be open. But at the same time, we cannot impose that on the family if the patient is not ready to receive it. Now, if somebody is not ready to receive it, there is a fear there. And my job as somebody who is trying to navigate this discussion would be to find out what that fear is. I don't need to talk about death to understand what the patient's concerns are. Once I know what the patient's concerns are, that will allow me to understand his mental makeup better, will also give me a hint and cue as to how fast or how slow I should be going with the dissemination of information. Okay, now please understand that patients can also use euphemisms. It doesn't have to be literally stated. You'll also find that somebody, we say that this person is in denial, but if you watch his behavior, he's not in denial. He's doing things to wrap things up. So we need to be very cognizant about not just what the person is saying, but also how they are behaving, and use these as cues to step further and further into that conversation. And the pace of that conversation is determined by the person who we are talking to. So that's one part. The second part, people have brought up age. I don't think age, see, when it's minors, you need the consent of the parent. And Param, I'm going to ask you to come in on the children's issue. But I don't think age really determines, unless, any adult age really determines autonomy. Param, do you want to talk about the minorities?
Okay. Yeah. First, I think that point you said is very great. It kind of adds on to the answer I gave, and absolutely, you said it right that it's not a question of just giving up. if we take time and build a rapport, we might so that is a very, very good point what you said, that we might turn it around and sometimes we want to know why they are not wanting to know. So yeah, great. I mean, you said it very well. Now the question of age, I mean, technically there is one technical answer to it. One is that yes, all the adults again fall into the category which we talked about. In minors, it can be, there's a lot of guidelines actually. I know if we can send to people, or you can check online about younger children. It is, age is one big factor where you may have to go through their attendants or parents or something. The other is assessing their maturity level. There's a lot of literature on assessing the maturity, and if a kid is mature, can we talk to them about death and how do we go about it? So it's a little longish, these things. I think it's better we read it up. So two things. One is a very small child, of course, we go everything to the parents. And if they are adolescent but not adult yet, we can individual basis. Sometimes people want to consider that too. So there are different views about minors, being talked about serious illness. In the elders, I don't know. I mean, as you said, elderly's age doesn't matter, that if it's a 48-year-old or a 70, 80-year-old. I keep mentioning what that movie, many of us, Smriti or Vandana, may have seen that Chinese movie. What's that? The Farewell. Yeah. So it deals with the whole of this issue. And in that case, the lady's playing along, actually. He possibly knows, and they don't want to talk about it. And but that is something which we are interested in, can see. It's very near to our own culture here in India. So that goes. Vandana, you want to say something about it, or anyone else?
Yeah, so I wanted to add in, like Smriti was talking about rapport building. So with Mr. M, it took me about a month, 2 months. So when everything failed, when immunotherapy also did not work, so we were in a counseling session, and he and I were sitting opposite each other. I held his hand. He, like Smriti said, he never wanted to talk of death directly. So he told me, ma'am, is it time now? Should I tell my wife to stop spending more money on the treatment? Instead, I would rather like this money to be saved, whatever there's left to be saved for my daughter. So, and I actually get goosebumps this was my last conversation with him. And he very clearly said, is it time now? So I said, yes, it is time now. And the rapport building took 2 months. And also, even at that point, he was not ready to say that I am going to die. So he put it across to me indirectly, that it's time to go. So yes, it does take time. So I think an effective communication may get you there. It takes some time.
Vandana, thank you. That is such a poignant thing that you just shared, because we need to be okay with that euphemism. We don't need to have it spelt out, right? And it might seem like one interaction, but it's a culmination of 2 months worth of rapport building for him to even think about that. Had that not happened, he would not even thought about having that conversation with his wife. So I think what was achieved there was really tremendous. I just also want to invite someone from, we have amongst us people who work with pediatric palliative care, and may I invite some of you to come forward with perhaps a couple of inputs on the children's issue. Although I do want to say that further down the line, we are specifically dealing with children and talking to children and how we do that. But I'll be very glad to hear from any of you, especially there's people from Golden Butterflies, there's people from various other quarters who would like, if there's anything you'd like to share specifically about talking to children, then please do give your opinion. You are the experts.
Yeah, I'd like to know. That'll be nice if someone raises their hand, because me being a adult neurologist, we don't deal with very small kids very young. So that'll be a good learning for us too.
So in the meanwhile, if someone does want to raise hands, by all means, please go ahead. In the interest of time, I'm also just going to move on to the next question in the discussion points, which Vandana raised, was that Mr. M has been put on best supportive care. Who can make him and the family understand this? So Vandana, do you want to just expand on that a little bit before we invite people to?
So best supportive care essentially means there isn't anything that medicine can do anymore. So it would mean, relieving pain, if need be, the need for oxygen, or maybe emergency services if the patient needs to be taken to the hospital on an emergency basis. So essentially, it meant there was no medical intervention to treat the carcinoma. So that's what it meant. That also was a kind of signal from the from the treating oncologist, that we cannot do anything else for you except provide palliative care to relieve the discomfort that you're going through. So that's what best supportive care means.
Hi, Smriti.
Hi, Stella. Please go ahead. I was just responding to your question.
Okay. No, I was just for the time of the short, I didn't want to hold you all back. Just wanted to know exactly what would you like us to know about what we are doing.
No, just in terms of, someone raised a question of talking to children about these kind of, how do you communicate with children at a time of advanced illness? If you want to just sort of say a few words about that, I think all of us would benefit from hearing you.
Thank you, Smriti. Yeah, it has not been easy for us because it's usually the parents whom we actually communicate with before the child. And as saying, most of the children, although they are aware, we are with a team of doctors and social workers and the nurse, and we sit along with them. And after that, as counselors, we take the parent alone. And so far, to tell you the truth, it has been not very difficult. Only 2 cases which were in very bad palliative state, where we did find it. It took us almost 2 days by the time we could get them to understand where they were and what was going to be the ultimate thing of the child, because they were very young parents and they were from the north. So it was not easy for them to really come to terms with it, which was very understandable. But since we are with the children and the parents from not exactly diagnosis, but from the time they are chronic, we have actually not had difficulty in getting them to understand, because it takes time and we do visit them on and off. I think at least once a week or twice in 15 days, we try our best to go and meet with the families in the hospital. Once this COVID started, we have not given up, just to let you all know. We have continued doing it by phone. And this is something that I think has not been difficult, because today everybody's got WhatsApp and they have a telephone number for us to get in touch with. So we have tried our best, and I think we are still a lot to learn. So I really am grateful to Pallium and to you, Smriti, in particular. Every day is a learning. So thank you so much. We are taking it forward. And just today, my manager and myself, we children for a case study. We were just chatting about that. So we thought we'll talk to you later in person and get something done on that. So thank you for this little time. Yeah, it's not easy, but it is workable.
Just hearing you and your resolve to make sure that the service is not interrupted is just amazing and very, very inspiring. Thank you very much to everybody at Golden Butterflies. I would also say that in the case of children, we have to be tuned into their behavior, because very often what is not said in words is expressed in behavior. And that's where we see whether it's grief that they're experiencing or anxiety that they're experiencing and things like that. So that's, but again, we will talk about that further down. It's interesting that a lot of the sessions we're going to be doing down the line are being signposted here already. So we'll move to the next. Thank you so much, Stella. And I'm going to come to the last question that Vandana had posed, is how important do you feel it is to communicate with the wife and the daughter? Please elaborate on that a little bit more, Vandana.
So once the patient was put in best supportive care, it's important for the caregivers to know what best supportive care means. It's not easy for a patient who's going to die. The patient has hallucinations, he'll be bedridden, there'll be bed sores, there'll be difficulty in breathing, there'll be continuous visits to the hospital. So at that moment, though, it's about the patient, but it's extremely important for the caregivers also to come in picture. So a proper communication with them becomes of utmost importance. So my question was, who would be the best person to tell them this? the oncologist or the social worker there or somebody else.
Let's get some responses from the participants present, and then Param and I can weigh in on that shortly.
Someone says whoever has the best rapport. So I guess I would tend to agree with them more or less. Yeah, that is important. And it also that who they want to hear it from also, if we can judge that, because sometimes they want to hear it from the treating team, that kind of a thing, that are we getting the right information, and we don't want to believe that kind of information. So maybe if it's a combination, according to me, it'll be the best. The news is broken to them by the person who has the best rapport, and maybe then confirmed by the treating unit or the treating attending doctor in charge, because people would want to double check sometimes that are we hearing the right thing. So that's my kind of personal thing. Smriti, you can also say what about that.
Yeah, so there's a lot of interesting answers coming. I also strongly believe that it's the person who has the best rapport, but yes, there is something to be said about who they consider the authority. Sometimes they do need to hear it from the attending team. But sadly, I think a lot of the time that's not, it doesn't happen exactly the way we hope it would. I would also even see, we're talking about the daughter and the wife, right, Vandana, in this case?
Yes,
Yeah.
yes, Vidhi.
Yeah, so I would say the rapport is important, and the important thing also is that the information will need to be repeated. When you first break that kind of news to someone, the response is, there could be shock, there could be intense grief, there could be disbelief. So information is not always processed fully the first time. So please be prepared to have the conversation again. And in that case, bring in the interdisciplinary team. Also important to speak to more than one person in the family. Do not rely on speaking only to the primary caregiver and expecting them to break it to the rest of the family, because emotions do color the information being passed on. So always, I would strongly recommend, if you can, this can happen over a period of a few days, please try and bring in different family members. Please, if you remember the assessment session, who is controlling the finances? That person needs to be spoken to, even if they're not the person by the bedside, because a lot of the decisions that will be taken will depend on the financial constraints or the financial capability. And if that person is not made to understand what is happening, then no amount of talking to the primary caregiver, who is a disempowered person. It could be an older woman who is not given a voice in the family. So that also becomes important. And this is where the genogram and all of that becomes important.
Yeah, it becomes important, right? Thank you, Smriti. So before we close the case, I just want to, add that the day Mr. M passed away, a couple of hours before that, he held his wife's pallu and he told her that, can I leave now? So she called me immediately and she says, ma'am, can I let him go now? I mean, she just needed, that rapport was there and she just needed that assurance from somebody, and she felt that close to me. She called up and said, can I let him go? And I said, if he's in too much agony and if he wants to, then you should. And a couple of hours later, he passed away. So yes, that's how it was.
Thank you for telling us that, Vandana, and what a moment for you also. But you've also raised a very, 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 very powerful point, which is permission seeking. That happens a lot. Yes. I don't know how many of us, and I'm going to ask, I don't know, Rajni, you've probably had this experience where people often die when the loved one has left the room for a few minutes. People want, so this letting go, this permission to let go, the permission to let somebody go, it's a mysterious phenomenon, but it's a very real one. And that's something that you raised. Thank you so much, Vandana. Param, over to you for final comments before we close.
No, I mean, it's as you said, we've lightened my work for the next week a lot by this discussion. But yeah, so a couple of things just in few seconds. So there's now a lot of research, even from our country, regarding that would they want to know or not, because this is a question all the time, and the general results are that people are way more ready or wanting to know than we expect them or their family members expect them. If we have the right data, we could bring across to the family members to allay their anxiety that they are not ready for the news. This can help us. So these are more than one studies done. We show 80 to 90% people really want to know, and some of them week by week prognosis. So it may be just a thought in our mind that they are not ready to know. They may be ready to know. So yeah, so that's something I wanted to say about that. I guess I've said what else yeah.
Thanks, Param. Thanks, Param. We will be coming back to the theme of communication repeatedly, because that's something that it's a skill we require irrespective of what part of the illness or what trajectory or which aspect of it we're dealing with. One more thing to just sort of leave you all with is the difference between death anxiety and death. Is it death people are afraid of, or is it the way people will die that scares them? Right? We've talked about this also, I think, where people would like reassurances that somebody's there, their distress is manageable. And those conversations can only happen once we build rapport, once we get to that point, elicit their fear. What are you afraid of? What are you afraid of? That's something that we need to ask, or maybe not so much in that, what are you afraid of, which makes people defensive, where they feel they need to be brave, but what is concerning you? What is topmost on your mind right now? And certainly give them some silence and some space. We've talked about times where it's taken 6-7 minutes for the person to answer. If you time 6 minutes, it's very long. So you need to be comfortable with the silence. You'll find that often 5-6 minutes later, the answers you get will surprise you. So with that, we come to the end of our session for today. Pallium India, Manisha from Pallium India has put in the chat box. Please click on that link and please give your feedback. Very important for us to keep improving on our sessions.